Bismillahirrahmanirrahim. Now we are starting the basic introduction to ascending and descending pathway. So actually we have to, this is actually intro lecture because our next lecture are going to be regarding ascending and descending pathway. So we try to clarify the basic terminologies regarding these tracts. So first we cover to the order of neuron, first, second and third, and upper motor neuron and lower motor neuron. One is regarding the ascending pathways, one is regarding the descending pathways. Ascending mean what? Something going upward, sensory pathways. So and descending means the motor pathway. So in sensory pathway actually we use 3 neurons, while in descending we only use 2 neurons. So we have to look at the arrangement actually. So before this, what is this?
This is brain.
Brain, and this is spinal cord. So actually our sensation which is coming from the muscles, they enter into this CNS part and then ascend
to brain.
The cerebral cortex, different area you can see, speech, smell, different according to sensation, type of the sensation. So they move upward and then the action signal or motor signal come down, descend and come to our muscles. From receptor to ascend, these are ascending pathway, then the descending. Same like the autonomic, so they are not in control. So if I wish to move, then the somatic will active. Alright?
Yes.
So you know better what is the difference between nerve and tract?
The nerve, the
outside the CNS.
tract inside.
And nuclei and ganglia.
Nucleus inside the cell body.
The cell collection of cell bodies inside the
outside. White matter is called
ascending. The white matter actually your myelinated axons.
Yes.
So this is actually nerve, and this here it become the tract. So let's see what's going on. So this is cerebral hemisphere, and these are the diencephalon. And the diencephalon between there, and the cerebellum here, and this is the brain stem. So continuous with your spinal cord. So we have to look at the tract. So can you see this is what central sulcus, the depression of sulcus, and the bulging is the gyrus.
Yes.
So these are the sulcus. So actually this frontal is associated with your motor function, and this parietal is associated with your sensory, and this occipital is associated with visual, and these are hearing and speech, this temporal.
Yes.
So there are differentiation point the sulcus, parieto-occipital sulcus and the lateral sulcus here, and the other sulcus which separate them. So an important concept I want to mention here is that, so these are the same things you know. I'm not going to these gyrus and the sulcus. So parietal lobe, frontal lobe, and the occipital lobe and the temporal. Just remember our concern with the sensory and the motor area. So sensory is associated with the parietal lobe and the frontal. So this is what central sulcus. We use 2 terms. One is the pre, mean first in front, and post mean on the back. So this sulcus, which is prior to this central, is what should name it? Pre-central. What should be on this side will be post-central. So here is the pre-central gyrus, and this is what post-central. Can you tell me which is concerned with the sensory, which is concerned with the motor?
Post is
associated with the sensory, because this is part of sensory system. Well, if you look at the motor, it is part of
motor.
The pre-central is part of your motor. So many students are confused with the pre-central, which one is concerned with the sensory, which one is concerned with the motor. You can understand here. So pre-central is associated with your motor, post-central is part of parietal. So that's why it is associated with the sensory. Just remember this concept. We will have to talk later here. So pre-central so we call them other name for this is the primary motor cortex, and the post-central is primary sensory, somatosensory. Somatosensory means somatic function. So we just look at the pattern of your. So this is your actually drawing simple diagram. So cortex then coming the thalamus, which is part of diencephala, medulla oblongata, and the spinal. I'm not mentioning all the structure. Our concern with the main. So we are using 3 neurons in the sensory. Our sensation goes. So our first is ganglia. So our first is the ganglia. Then the first we have to locate the cell bodies or their collection of cell body nuclear. So 2 are very simple. So one you know better is the dorsal root ganglia, which is outside the CNS. So sensory pathway is clear. And the last setup is going here. So in the precentral, postcentral for sensory.
Yes.
So other nucleus will present at the postcentral level. So first the ganglia is present outside the CNS. So if we are able to define the second nuclei, we can easily define the pathway. So let's start. So these are actually your internal capsule. So here is actually there are 2 limbs. One is the posterior, one is the interior. So for example here, this is interior, this is posterior. So they are joined like this. So this junction is actually we name them genu. So just remember the posterior limb is mostly concerned with. So these pathway actually cross this posterior limb of the internal capsule. So here this is the post central, and I am dividing right into left. Are you clear?
Yes.
No problem. So this is actually the third nucleus here, and we call them the ventro-posterior-lateral nucleus. What is name? Ventro-posterior-lateral nucleus present in the thalamus. So this is our the third nucleus. So this is our second. So actually, what you are going to see, this is your first. So first is its ganglia. This is second nucleus, and this is third. So actually there is concept. Your first is easy, is outside. Third is in the thalamus. It's common for all of it. So concern is that this second. So actually you can see this is present on the other side. For example, this is the left, this is the right. So if this is present in the right, so they have to cross here. Or if they come here, so they have to cross at this level. So depending upon your second nucleus, so the decussation means simply crossing. So crossing can be defined by the location of the second. If it is present in the spinal cord, so they have to cross at this level. Easier? And if it is present here, so they come here. First is outside,
Yes.
it's easier. The third is here on the other side. So from the left side, they have to go to the right side, because their sensation are this side, because of cortex, cerebral cortex.
Yes.
So right is concerned with the left, and the left is concerned with the mainly right. So this signal which are coming from the left side, they have to cross on the right. So there should be a level where they have to cross. So either their level be at the medulla level, either their level be spinal cord. So depending upon the nucleus, if it present in the medulla, so the crossing will be at the level of medulla. So if it present in the spinal cord, crossing will be at the level of spinal cord. So let's see. So this is here is what in the spinal cord. So crossing will be here, and this is your other where going to the medulla level. So let's see what's the name. So the crossing occur right here at the level of spinal cord. So it's going to ventro-posterior lateral, and look at this. It's crossing occur at this level medulla. So this is called decussation actually. So what you can see, one decussation here, one is here. So the word is decussation or crossing. So this concept is clear?
Yes.
Let's see. So these are your third neuron. So can you see this is our first order neuron? It may end in the spinal cord, it may end in the medulla, depending upon their second nucleus. So the second is coming from here. Alright? And third is coming right here. Are you clear? So when we discuss the ascending and descending pathway, actually when they enter into our clinical one, that is the lesion. So we able to define the lesion and their the sense losses. So let's see. Can you tell me, here is loss? Can you see this injury showing this point? So can you tell me? So there problem will be on which side. So because if this is the right, so this is the ipsilateral and this is for contralateral. So sensation are coming from contralateral. So if there is injury at this level, so sensation last will be on the
Right.
contralateral side.
Contralateral side.
It's clear. So if there is injury at the upper level, so the for example in the thalamus or the cortex or internal capsule, any level regarding the third motor neuron, so they will be on the contralateral side. Easier.
Yes.
So let's see. There is another decussation, for example here. So subtle will be on the
Contralateral side.
contralateral side, although it's associated with the second.
Yes.
But depend upon the level. So if it's above the decussation level, losses will be on the contralateral side.
Contralateral side.
If they is below the decussation, the losses will be on the ipsilateral or ipsilateral mainly. So if this level
Yes.
is for example here is, so for this track will be on the
Right.
ipsilateral. For this track will be on the contralateral because they have to cross the spinal. So you need to understand if there are decussation at the medulla level, so that those tracks which are decussating at the medulla level, so they are for example here, so their losses will be on the ipsilateral side. Any level injury in the spinal. So for example injury right here, so there will be on the ipsilateral. For the other track, contralateral side. You're genius. So above the decussation, contralateral. Below the decussation, ipsilateral. So now look at this neuron. So in the first neuron, any level, losses will be on the ipsilateral, contralateral.
At this level, ipsilateral.
Ipsilateral. Of course, it's because the first is always present in the ipsilateral side.
Ipsilateral.
Second has to cross. So depending upon the crossing level, it is above the decussation level, contralateral. Below the decussation, ipsilateral. First one, neuron. So this is actually your dorsal column medial lemniscus pathway. So why we call the medial lemniscus? Actually, dorsal column. What is the function of the dorsal column? Can you tell? Fasciculus gracilis and fasciculus sigmoideus. Its main function is associated with the proprioception, or your sense of the inner body, the joint position, and the vibration, repeated pressure sensation, and the other total discrimination. So this is actually if losses on this level ipsilateral, so the losses will be on the ipsilateral, the proprioception and the vibration and the total discrimination of this side for because it's left. This is actually your spinothalamic, which is associated with the pain and temperature. So we call the medial lemniscus. Actually, this is medial lemniscus. So crossing at this level, they are actually forming internal arcuate fibers. So they are actually moving like a bundle. So like this. So they are actually moving like this. So they crossing. So this is at the because it's shown one, but there are bundle of them. So as they cross here, so they form a lemniscus also or a bundle. So that is called lemniscus because it's medially while the other is present, which is on the lateral. So we named that. Actually, lemniscus is what? Medial lemniscus pathway is what? Dorsal column. Because bundle around because of crossing at this level. So that's why we named the medial. This is spinothalamic. You know better. P and T, pain and temperature.
Yes.
So their losses, if I define the, for example, losses at this level. So pain and sensation contralaterally and the sensory proprioception, vibration, everything is on the contralateral at this level.
Yes.
At this level, both
Contralateral.
above the decussation. At this level, some contralateral,
And some
some ipsilateral. So because if losses here, so other type is coming right here, so they also cross at this level. So if there is injury, so same like here, so other will be. So the losses will be the pain and temperature on this side, and the this side, pain and temperature this side, and the your proprioception and vibration, total discrimination of this side. Because I am showing one, other will maybe cross here for this side, I shown the one side, so other side will be cross here. So the injury at this level, so sensation contralateral and ipsilateral.
Both.
So easier way to remember, if you find in the scenario where you find the only word contralateral, mean there is above the decussation. If you find the there is some ipsilateral, some contralateral, mean it's in the spinal cord, easier. So because here, so some has crossed, some has, but at this level everything has crossed. Doesn't matter spinal cord, doesn't matter the medullary, nucleus. So they cross. So mean there is no need to take MRI of their spinal cord because everything is contralateral. Mean it's associated with the above the medulla. Genius. So now come to the motor pathway. So this is actually ascending. Now come to the descending. So actually I am mentioning three levels: cortex, medulla, and spinal cord. So here is scenario is that when you read any muscle, you say the nerve of that muscle is radial, that is ulnar, that is the facial nerve, that nerve. That is actually we are talking about the lower motor neuron. That is the lower motor, which is actually supplying. So they are coming from here because we have spinal nerve as well as the cranial nerve. If their supply is the cranial nerve, so the lower motor neuron will be cranial. If there is the spinal, so their lower motor will be. So other pathway which is neuron, which is coming from your cortex, reaching at that level, because if L2 level they have to, so they, because when I mentioned for example the for the leg muscle, so 2, 3, 4, 5, so for the sciatic nerve or other nerve, so the signal which are coming from our brain, so other neuron is used. We name them the upper motor neuron. Easier?
Yes.
So what is the center of the motor pathway? Pre-central does.
Yes.
Pre-central for the motor, post-central for the sensory. We have discussed post-central. Now come to the pre-central pathway. So this is right and left. So these are what internal capsule. Easier. So here is for example muscle. So coming from sensation are coming from the pre-central carriers. So here you see one nucleus present here, other present here. Other is present at their level where they have to supply the muscle. So let's see. This is our upper motor neuron, which is coming from the pre-central carriers to their level. Easier. So these are motor neurons. So this is upper motor neuron. So they decussate at the level of medulla. You can see here.
Yes.
So and here is the lower motor neuron. So this is upper motor neuron. This is lower motor neuron. So decussation is at the level of medulla. So now let's see what is the function of actually the upper motor neuron and lower motor neuron. Actually, the I say the extension or flexion, voluntary muscle action. So they are considered by the lower motor neuron, but I am not go to overactivity. So there is some stimulatory as well as the inhibitory signal coming by this upper motor neuron. So although there are some stimulatory and then there is inhibitory. So the concept I am sharing is the $1 million. So you need to focus. So overall effect, something all the stimulatory and inhibitory, but overall effect is the inhibitory. So their overall is inhibition somewhat. So mean if for example I want to extend this muscle. So if I lose the inhibition, mean what? Overextension.
Right.
Overactivity. So mean if there is losses in the upper motor neuron, the what should be our clinical finding will be the hyperactivity, hyperreflexia, hypertonicity. Are you clear with this?
Yes.
While on the other aspect, if there is injury in the lower motor neuron, action because there is no nerve is going to the muscle, so the action will be the hypoactivity, hyporeflexia, hypotonicity. Easier?
If lower motor is damaged or something, hypoactivity.
Yeah.
If upper motor is damaged or something, hyperactivity.
Hyperactivity. So let's see. So this is upper motor neuron injury, and the finding will be on the contralateral ipsilateral. Contralateral. So if at this level, ipsilateral mean there if there is injury above the medulla, will be on the contralateral losses, motor activities, and if there is on the
below the
spinal cord level or below the decussation, so they will be finding on the ipsilateral side. So at this level, so also the ipsilateral, but these are the upper motor neuron lesion. This is the lower motor neuron lesion. So below the level of lesion. So I will explain it later. So what is going to above the decussation, contralateral. Below the decussation, ipsilateral. Easier. So spastic paralysis. So the paralysis in this case is somewhat you cannot contract the muscle much.
Yes,
So there is rigidity is a different thing. Don't confuse. I will explain later. I am not going to much detail here. So, but there is spasm in the muscles like this. So these conditions are considered as the upper motor neuron lesion. So stiffness and rigidity. So hyperreflexia.
upper or below?
Upper motor neuron lesion.
Upper motor neuron hyperactivity.
Hyperactivity. Because their overall effect is inhibitory. So I am stopping the inhibition mean what? I am allowing the action up.
Yes.
Are you clear?
Yes.
So hyperactivity, hyperreflexia. So muscle will become overactive, easier. No muscle wasting. Because why there is no muscle? Because you can see lower motor neuron is still okay.
Yes.
So if there is no because no muscle wasting will be in case of when there is lower motor neuron lesion.
Okay.
It's okay, innervation are coming, but there is activity is going more.
Yes.
So, but sometimes this use so because I cannot move our muscle.
Yes.
So due to this 10 or 20% there is muscle losses, the atrophy we call them simple. But in case of lower motor neuron, your muscle going to waste because there is no nerve.
Yes.
Easier. So class knife capacity mean there is problem in the initial movement. Then easier. When you have seen some knife when you open them, there is some problem in the initial movement. Then actually open.
Yes.
Something like that. So like here. So if for example here. So initially there is problem. Then yeah. Okay. So there is resistance in the initial movement. Then easier.
Yes.
So this is all condition of the upper motor neuron lesion. So Babinski sign, upward fanning. So actually, when you do the Babinski test, so when you move like this on your toe level, so your toe is going to up Babinski sign because they are upper motor neuron, because there is inhibitory effect. So they are not allowing to upward movement. But if the upper motor neuron mean there is no inhibition, so they fine out. So these are Babinski sign. Normally there is no Babinski sign because upper motor neuron is. If I test right here, you can test wrong. So no, because you are normal. It is only condition for the upper motor neuron lesion. So lower motor will always on the ipsilateral, easier.
Yes. Yes.
So and the flaccid paralysis. So that is the stiffness somewhat. But in flaccid mean bumpy, floppy type muscle. This leg. So this is flaccid will decrease muscle tone. So fasciculation mean you are because there is mechanism. Just remember there are actually involuntary movement because when lower motor neuron is stopped. So your acetylcholine level is going to decrease because they are neuromuscular juncture. So muscle thinks something that I have maybe lack of some receptor. That's why acetylcholine. Actually, condition is what acetylcholine is like level is low, but muscle think that there is lack of receptor. So they generate more and more receptor to take those the acetylcholine. So that's why some involuntary movement. So they have no control over their movement. So involuntary movement are associated with this lower motor neuron lesion. So, and muscle wasting because no innervation.
Yes.
So, and there is areflexia. I mean, when you try to check the reflexes,
Yes.
so loss of reflexes. So, and the normal plantar flex mean negative meniscus side. So,
Yes.
flex easier. So, there is a example for this lower motor neuron lesion is the poliomyelitis Wardney-Hoffmann disease. So, these are actually example. I will explain their mechanism when I discuss this spinal cord lesion, just because it's intro.
Yes.
So it will help you. So this is only lower motor neuron lesion example. So this is another example in which you find both type of lesion. Actually, their condition in which you have combined. For example, if I loss is at this level, C5 for example, which is associated with your bicep muscle. So there are some finding at the level. There are some finding below the level. So, for example, at that level, so finding will be lower motor neuron because, for example, I have damage here.
Yes.
So this nerve is going to be lost because this is lost. So, but below that is the upper motor neuron lesion there because then the nerve is okay.
Yes, yes.
If I move down, also I have damage here. So this lower motor neuron is injured. But below that is the upper motor because I have stopped the upper motor neuron right here. So they are not going down. Are you clear with this stuff? So at that level is the lower motor neuron level. Below that is what? Upper motor neuron lesion. So such kind of condition I have mentioned that below level of lesion is upper motor neuron lesion and some finding are at the level of lower. So for example, if there is you have damaged the nerve of your bicep.
Yes.
To check the contraction. But what will happen at that lesion is something like that. You will find your knee jerk is going to hyperactive. Why? Because there is upper motor neuron. So their action will be hyperreflexia, hyperactivity. So now let's discuss the one concept which is your reflex action. Little bit. So I mentioned the hyperreflexia and reflexia. Now, what is the pathway for the reflex? The reflect receptor from receptor signal, afferent signal go to the spinal cord, and spinal cord then send back the afferent neuron, afferent which are going to affect the muscle. So, for example, if I touch some hard thing, so such kind of actually your the reflex action. So this is actually your lateral corticospinal tract, which is associated with your mainly with the somatic function. So pyramidal tract. So actually, when you see pyramidal, so can you see crossing right here? So this crossing, for example, other is crossing here. So something like that. So they form like a triangular pyramid shape at this level. So that's why we name them the pyramidal tract. So the cortical spinal, spinal means spinal cord coming from the cortical going to the spinal cord, and the other for the which is the because you have spinal nerve as well as cranial nerve. So this is for the spinal nerve. Other pathway which come for the cranial nerve. Cranial nerve are present mainly in the brain system. So the pathway which is the nerve, it's coming from your cortex, reaching at the brain system or your the cranial nerve. So that is corticobulbar. Corticospinal going to the spinal cord, corticobulbar going to the brain stem or your cranial nerve. So they also decrease. So we actually both of them crossing like this. So that's why we name them the pyramidal tract. And the extrapyramidal other pathway which are other than the corticospinal, corticobulbar are considered as the extrapyramidal pathway. So this is a description you can read out yourself. I'm not going to explain here. So one condition I'm just explaining at the end of this lecture. So Brown-Sequard syndrome. It is actually hemisection of one part of your. For example, you have right or left side. You have sected. What should we find at the level of lesion? You should know better. And below the level of lesion. So at the level of lesion. Because ipsilateral your lower middle, you know better. At the level is lower middle. Up below the level, what should be? Upper motor neuron. Finding if I have hemisected our spinal cord, it is actually when a gunshot or someone had put the knife. So such kind of condition is actually your Barum syndrome. Ipsilateral loss of all sensation. So because you have a lesion at the level of the spinal cord level, so you have hemisection of is the ipsilateral upper motor neuron lesion. So loss of tactile vibration proprioception. Why? Because these sensations are going because it's associated with your dorsal column, tactile vibration proprioception. So and the pathway with dorsal column effect and contralateral your upper motor neuron. So because some pathway they are going ipsilaterally and some are going contralaterally. So and the loss of pain and temperature, because you know better the pathway spinothalamic tract, they cross at the level of spinal cord. So while those pathways which is dorsal column, they move at the level of cross at the level of medulla. So their condition is the ipsilateral, and for the pain and temperature, the condition are on the contralateral. So this number one is actually level of lesion. So your loss in all these findings, the ipsilateral, your lower motor neuron, you know better. Motor function is lost, and both are you need to consider sensory as well as the motor pathway because both are moving here. So while the all sensations which are going to this side have been lost because all the tract which are coming right here, so there is no pathway which is allowing to move here. So while if you look at this level, so can you see a difference? One or two segment here. This is actually your the pain and the motor neuron which is crossing at this level. So they are actually cross one or two when they enter like this. So they are not crossed at that level. So they move one or two segment above. So mean if injury at this level, so the track of this are crossing at this level. Are you clear? Yes. But if, for example, the pathway is coming right here, so signal are coming right here. So these signal are actually crossing at this point. So they move your loss of tract you have mentioned here. Yes. So they move one or two segment above, then they cross. So if there is injury at this level, contralaterally, the pain and temperature losses are one or two segment below. So you can see here. So this is you are actually showing the loss of pain and temperature, and here is tactile vibration proprioception losses, and at the level lower motor neuron lesion, above the below the level is the upper motor neuron type of mean your hyperactivity, hyperreflexia, all those. So there is condition if this lesion is above the T1 level, so it's going to become the ipsilateral Hallner syndrome. So name for that. So in the, you will find the constricted pupil and eyelid drop. So this is the end of our present lecture. Then we'll start the ascending and descending pathway.